keynote address on chorioretinopathy and deep impact of ocular trauma. Yes.
Thank you,
Sanjit.
sir. So good afternoon, everyone. Today I'll be speaking to you on chorioretinectomy for deep impact ocular trauma in Indian eyes. So the concept of chorioretinectomy is quite old. Was first done by Sivozinovic in 1987, but a prophylactic chorioretinectomy was first performed by Ferenc Kuhn in 2004. And this chorioretinectomy is done in deep impact ocular trauma with vitreous incarceration or choroid penetration. And it reduces the RPE proliferation, fibrous ingrowth, and PVR from the wound site. It can be done as a prophylactic or a therapeutic procedure. So to understand the concept of chorioretinectomy, let us see this case. This was a patient of endophthalmitis, a double penetration wound with endophthalmitis. So we sutured the wound, we did a vitrectomy, and you see there was an exit wound along the inferotemporal vein. So we decided not to touch this wound at this moment, and later on post-operatively the patient developed this severe PVR and ERM from this wound site. So again we had gone in, and so we did remove the ERM. We did a diathermy. These diathermy burns are 100% deep. So we did a deep 100% diathermy, and then we remove the retina and the underlying choroid using the diathermy and the vitrectomy cutter. So after this, the patient did quite well. There was no recurrence of PVR or the epiretinal membrane formation from the exit wound. Otherwise, you will just keep on removing the ERM, and again the ERM will come back and give you a poorer vision. So this patient ultimately gained a vision of 6/18 in this eye. So we did a small study to evaluate the success and limitations of performing prophylactic chorioretinectomy for deep impact ocular trauma in Indian eyes. It was a retrospective case series. 11 eyes of penetrating eye injury with or without intraocular foreign body was studied. The vitreous was incarcerated in posterior retina in all these eyes. The visual acuity was more than PR accurate in all these eyes. Either a 25 or a 27 gauge vitrectomy with wide angle non-contact viewing system was done. The procedure involved the excision of the vitreous base, the removal of the foreign body if it was present, the chorioretinectomy followed by the endo laser, and gas or silicone oil tamponade depending on patient to patient. The method was that deep 100% endodiathermy was done around the incarceration site. The uncarcerated retinal tissue and the underlying choroid was removed till the level of the bare sclera. 1 to 2 rows of prophylactic laser around the site was done, and any bleeding which was happening during the time of chorioretinectomy was controlled using the diathermy or increasing the infusion pressure. So results, the demographics, they were all male patients. The average age was 28.3 plus minus 12 years. The intraocular foreign body inside the globe impacted in the posterior wall was seen in 7 of these eyes. The exit wound was seen in 2 eyes. There was a patient with a knife injury in 1 eye with a vitreous incarceration posteriorly, and there was a patient with cow's horn injury in 1 eye. The associated retinal conditions were seen in these patients. There was retinal detachment in 4 of these eyes, endophthalmitis in 1, significant vitreous hemorrhage in 4 of these eyes, and subretinal hemorrhage in 2 eyes. And the surgical steps, the silicone oil tamponade was used in 5 out of these eyes, and gas tamponade in 4 eyes. 2 eyes we just used the air tamponade. Post-operatively, retinal attachment was seen in all eyes. Recurrent PVR occurred in 2 eyes. The visual acuity improvement occurred in almost 10 out of 11 eyes. And there was a branch retinal vein occlusion affecting vision in 1 of these eyes. So this is a patient of intraocular foreign body which was impacted into this wound. And so the foreign body was removed. It just shows the procedure, how we did that chorioretinectomy. You do 100% deep diathermy burns around this impaction site, around this incarceration site. And then you just, with the vitreous cutter or even with your diathermy also, you can melt the choroid. So you just remove the choroid and the overlying retina with the vitrectomy cutter. You see there's small bleeding, but that can be controlled easily by raising the bottle height or by doing a diathermy at the bleeding site. Foreign body was then removed through this scleral incision, which was later on sutured. Then the fluid air exchange was done. Endolaser was done around this, the area, and gas was used as tamponade in this patient. So this was post-operative. The patient had a visual outcome, a good visual outcome. His vision post-operative was 6/6. So another patient of which I spoke of, there was a Kaushan. There was a total vitreous hemorrhage with anterior incarceration of the vitreous, then retinal detachment with subretinal hemorrhage and posterior incarceration in this patient. And post-operatively, the patient regained a good vision of 6/18. You can see the chorioretinectomy scar in the temporal periphery of this patient. This was another patient of double perforation with the perforation in the macula, sparing the fovea, and we did a chorioretinectomy. This patient did very well. The vision improved to 6/9. Another patient of impacted intraocular foreign body. This was a patient of a suprachoroidal intraocular foreign body with the fibrosis, and there was no other way to remove that foreign body except doing a chorioretinectomy procedure. So we had to remove this choroid. This was a patient of who had an injury with a knife. He had a retinal detachment with vitreous hemorrhage with incarceration. Then we had to do a chorioretinectomy in this patient. So this is a small video of the patient who had this hemorrhageal chisel injury with intraocular foreign body. So this was the patient that I was speaking to you about, the suprachoroidal foreign body. You see this fibrous band was there. This was nasal to the disc. This was pulling up the retina. So we had to do a vitrectomy. Then we did base excision. We separated the fibrous band, and we created this chorioretinectomy scar just nasal to this disc. And then we did a chorioretinectomy here. And when we were looking for the foreign body, it was nowhere in the eye, but it was in that suprachoroidal space here. You see, once we removed the choroid, then we found that there was this foreign body which was impacted here. And then this foreign body was again separated, removed, and just finish this off. So to conclude, chorioretinectomy is a relatively new procedure, but it may prevent exit site wound-related PVR and fibrous ingrowth over the retina from the wound site, and it may be considered as a prophylactic or a therapeutic option. Thank you.